Good afternoon, everyone. It's my pleasure to host you here for the Journal Club on the age and time-dependent increase in incident anti-GBM disease, a nationwide cohort study, presented by Dr. Karl Emil Nelveg-Kristensen from Copenhagen, Denmark, a nephrologist with a PhD in epidemiology and experience in Cambridge at the lab of David Jane. As panelists, we have Lauren Floyd, renal fellow and doing currently a PhD in the UK, in the Manchester University. And then we also have Dr. Ivkovic here from the University in Croatia, a nephrologist with a special interest in vasculitis. I will also introduce my co-moderator here, Andreas Cronbichler, which we know, of course, as a colleague with a special interest also in vasculitis, and currently has a position in the Innsbruck Medical University. My name is Amaryllis van Craenenbroeck. I'm a nephrologist in UZ Leuven, Belgium, and I'm very looking forward to the presentation of Dr. Nelveg-Kristensen.
Thank you very much for the introduction, and thank you for the interest in our latest work in the area of anti-GBM disease, which is work done for the Danish nationwide Danish Vasculitis Association called DANVAS. And I'm glad to present this paper called Age and Time-Dependent Increase in Incident Anti-Glomerular Basement Membrane Disease, a nationwide cohort study. So anti-GBM disease is a rare small vessel vasculitis that affects glomerular and pulmonary capillaries, resulting in a rapidly progressive glomerulonephritis and pulmonary hemorrhage, with subsequent high risk of chronic renal failure and death. So due to the very low incidence of this disease, which approximates about 1 case per million per year, it has been difficult to do proper epidemiologic assessments, and most epidemiologic studies have relied on selected data from specific centers, making it difficult to ask normal or usual epidemiologic questions. So based on the unselected data from the Danish nationwide administrative registries, we set out a retrospective cohort study to investigate age and time-dependent changes in classical epidemiologic endpoints, such as incidence, disease demography, renal survival, and patient survival. We also set out to investigate the occurrence of double positivity of anti-GBM antibodies and anti-neutrophil cytoplasmic antibodies in this cohort. In Denmark, all civil status laws, I'm just explaining that. So in Denmark, every citizen has a unique and personal civil registration number that enables cross-referencing of all the Danish administrative registries. Data from these registries are then collected and maintained by a governmental organization called Statistics Denmark, which then provides the access for anonymized data for searchers such as myself. So in this study, we included all patients with incident anti-GBM disease defined by ICD-10 code between 1998 and 2020. Before the study, we did a pilot study of 19 patients identified by ICD-10 codes and went through their patient charts, record, and found a positive predictive value of 100% for these ICD-10 codes. As for the survival analysis, we included population controls who were matched 4:1 by exposure density sampling on age and sex, and then also a ANCA-associated vasculitis population with and without renal replacement therapy. We employed or used several of usual statistical assessments, and I'm not going to go through them all, but we did assess cumulative incidences by Olsen-Johansen estimator and time-specific Cox regressions, was used to model absolute survival probability at 1 and 5 years, and we also assessed risk based on absolute risk ratios. So we were able to identify 97 patients during the study period with a median age of 56 years and a 50-50 female to male ratio. So looking at the age stratified groups, we saw that patients less than 50 years were, there was a clear predominance of men among the patients less than 50 years, whereas there was 60 or around 60% of the patients more than 50 years were female. Overall, there was a higher burden of comorbidities among the older patients, not surprisingly. However, each of the subgroups were, with very low figures, so we are not able, due to our anonymizations process, we were not able to show the correct figures here, but overall there was lower comorbidity burden in the younger patients. All right, so during follow-up, 58% of the patients were relying on renal replacement therapy at day 30 after initial diagnosis, and 63% of the patients were on renal replacement therapy at 1 year after initial diagnosis. 35% were in the class of advanced disease, defined as by the length of their initial hospital stay, and we employed plasma exchange in 74% of the patients, which is slightly lower than you would expect, and I guess we're going to discuss that later. So 37% of the patients went on an ICU stay, intensive care unit stay, and approximately 20% had lung hemorrhage. These figures are quite similar to what's been shown in other epidemiologic studies, actually. So again, looking at the groups differentiated by age, this is not statistical significant, but there was a higher percentage of patients relying on renal replacement therapy in the age group above 50 years. And also advanced disease was also higher among the older patients. At least they were the ones who had a longer hospital stay. So conversely, we saw far more lung hemorrhage, or episodes of lung hemorrhage among patients younger than 50 years. So during the study period, there was an increase in age, actually, a significant increase in median age, started around 40, mean age of 40 years in the early years, and then rising towards a mean age of 60 years in the later years. And also in the same period, we saw a shift of so an increase in female gender during the years, a shift so that more than 50% of the patients were women after 2005 and onwards. So also we did see a change in incidence during the years, with a lower incidence in the early years, around 0.5 new cases per million per year, increasing towards about 1.4 new cases per million per year in the later years. And again, looking at the different age group, there was a significant and marked increase in incidence among the patients more than 64 years of age. So actually, we saw these two slides taken together. We saw an increase in incidence. It was primarily among the older patients, and among the older patients there were more women. So this is probably driven by older women, this increase we see at least in the later years. Also, we did do a sub-analysis, and we did see increase in both men and women during the years. All right. With the overall incidence stratified by age, we did see a bimodal configuration, as also mentioned in previous studies, peaking around the second to third decade in life, and then again above the patient groups who were older than 70 years. And this is just the total frequency count that is underlying our incidence calculations. So we did do also look into serology, and were able to identify 32 of the ICD-10 code confirmed patients with anti-GBM disease. 32 of those we had access to serology data, and found that 40% of those patients had double positive serology with both anti-GBM antibodies and ANCAs in their blood. And there was a slight predominance of MPO ANCA among the double positive patients. Double positive patients were also older, with a mean age of 62 years, and there was a clear predominance of female gender in our study. The peak anti-GBM concentration was lower in the double positive group. So looking further into the serology testing, we had access to 4 out of 5 regions in Denmark. We did have access to biochemistry data from 2013 and onwards. And we did see a quite marked increase in anti-GBM testing incidence during the years. And we also saw a modest increase in positive anti-GBM serology incidence, here shown in the red line. There was, of course, the increase was very much slower, but the increase was, and the total incidence in positive anti-GBM serology incidence was quite much higher than what we saw for ICD-10 code-based incidence, and that we took that as a indication that there must be patients with a positive anti-GBM serology who has not got the disease. Mention here is also we need to know that a positive anti-GBM titer here is just above. It gets positive if you are above the upper normal level. So coming to renal survival, we saw that there was an increase in renal survival from 2007 and onwards, which is kind of funny because it was also seen in another study previously by Van Dalen back in 2018. And they also saw an increase in renal survival from 2007 actually and onwards. This is probably something to do with when we diagnose patients. We probably are better in diagnosing them at an earlier time point due to the more extensive testing we've seen in this earlier slides. Mortality was seen, so 36% of the patient died during the follow-up, and 26 patients died within 5 years, which leaves us with a 5-year mortality rate of 26.8%. And the primary contributing causes of death was cardiovascular disease, vasculitis, cerebral disease, and infection. There was no significant change in 1-year survival during the years, but visually there was a decrease in the 1-year survival, in keeping with an increasing older age in our population. Also, 1-year survival by age was definitely decreasing. So the total mortality at 1 year and 5 year was definitely and significantly higher with anti-GBM disease as compared to the general population, but it was comparable with a dialysis-dependent group of patients with ANCA-associated vasculitis. We also found that there was a significant decrease in survival probability for the anti-GBM patients that were relying on renal replacement therapy at day 30, stressing the impact from end-stage renal disease in this population. So this is the cumulative incidence of death over the years, and there was actually the dialysis-dependent AV group and the anti-GBM group were actually quite similar during the first 2 or 3 years, but then they suddenly started to depart, and it seems that the cumulative incidences increased for ANCA-associated vasculitis, maybe in keeping with the relapsing nature of this disease as opposed to the nature of anti-GBM disease. Survival probability based on years of life from diagnosis was also increasing, meaning that for patients at the year 0 from their diagnosis had a severely decreased survival probability at 1 and 5 year. But then if they survived 1 or 2 year or 3 years, you saw the survival probability of 1 year survival probability and 5 year survival probability were increasing. And then again, after 4 to 5 years, you saw the survival probability again started to decrease in keeping with the high number of patients relying on renal replacement therapy in this group. So this brings us to the conclusions that, and I've just written here some points, bullet points. So incidence of anti-GBM disease increased over the test period, possibly related to temporal demographic changes, more extensive screening, and better registration of patients or the disease. So age-stratified incidences exhibited a double peak configuration as shown before, peaking around 20 to 25 years of age, and then again above 70 years of age. Also, mean age seemed to increase over the time in conjunction with the percentage of female gender. So double positivity was likewise associated with female gender and higher age, but also lower mean anti-GBM titer and a slightly higher frequency of MPO-ANCA. And this poses the question, are double positive cases driving the observed increasing anti-GBM incidence? And does this group of patients confine a separate disease entity with a different pathogenesis? So mortality remained markedly higher than in a age and sex matched background population and was comparable with a cohort of dialysis-dependent AAV patients. And 1 in 5 year survival probability increased towards the baseline population during the first 3 years after diagnosis, whereafter it again started to decrease in keeping with the higher percentage of patients dependent on renal replacement therapy. So this was the study. Thank you. And yeah.
So yeah, so congratulations again. I wondered whether or not you could just tell us a little bit more about your inclusion criteria and whether or not all of the patients included were biopsied. I think that was part of the inclusion criteria, but I couldn't work out whether all patients were actually biopsied or not, and whether or not that affected anything.
So for the total study group of the 97 patients, they were defined by ICD-10 code, purely ICD-10 code, which was why we did the pilot study to define whether or not we could rely on the ICD-10 code. So this makes it, and then afterwards, post-hoc analysis, we did 2 assessments of our study cohort where we applied 2 different sets of definitions to find out if we can kind of reproduce the population in other ways. And we were able to identify around 80 to 85% of the patients once again by applying a new set of criteria. And these set of sets, so one of the definitions were actually has previously been validated in another study. So this is the deal in our type of work, that we don't have all the clinical data available. So we have to rely on proxies and ICD-10 codes and other ways to define patients.
Great, thank you.
Yeah, can I do the second one? Great presentation, Karl, Emil, and a very nice paper. Gives us a lot of not only epidemiologic but clinical evidence which we can infer from epidemiology. And I think it's important to note that it's the first such paper. It has never been done. It has never been done before, such an epidemiological study on temporal trends in such a rare disease, which is not an easy task by any account. So I wanted to ask a two-pronged question. The first part would be, I very much like the conclusion of ANCA as a driver for anti-GBM disease. Because ANCA is 15, 20, 30 times more prevalent than anti-GBM disease, it has a much higher incidence than anti-GBM disease. Do you think that maybe small rises in the incidence of ANCA vasculitis, which you proved with your last paper, could lead to a larger increases in anti-GBM disease, given the very much different incidence rates of the two diseases? So if it could be an epidemiological driver. And also you postulated that very well, and it has been discussed before. Could you tell us something about the possible causal relation of anti-GBM and ANCA, especially on anti-GBM disease subsequent to ANCA vasculitis?
Well, thank you for the questions. So I guess this is of course slightly out of the epidemiologic angle that I've made, but I do think, and others has also proposed, this kind of relationship between anti-GBM disease and ANCA-associated vasculitis disease. So we have around 40% of the patients in this paper and about 35% in other papers of double positive patients. And if you look at the ANCA group, the pure ANCA-associated vasculitis, so the double positivity here is only 5% of the patient. So the thing is that in the right kind of immunologic milieu and genetic setup, if you have, for instance, MPO ANCA-associated vasculitis, you will expose, due to the disease, some proteins that will make you prone to maybe create anti-GBM antibodies, and then over time you will probably then develop the disease. And that what fits into that kind of theory is also that you actually see a more modest increase in so you have only a lower titer of anti-GBM in the ones that comes in with a double positive anti-GBM disease. So I do think there could be some kind of relationship there, but this is just theoretically kind of thinking about how could this actually come together. So I have no definite proof of anything here. So that's and because it's kind of I believe that this is maybe the case, and of course if that's the case, as we saw in our previous study in ANCA-associated vasculitis, we saw actually the same trend. There was a trend in increasing incidence, and we also concluded that has to be because of the increase in testing, which is evident in that period as well. And of course also because of the increase in the population, the demography of older patients. So you have a higher percentage of older patients who are more prone to have this disease, and you will find more, of course, if you test more. So that's probably it.
Great answer. That's what I was looking for. I thought it was very good to mention this potential causality where maybe ANCA results in some epitopes being denuded and then seen, and then person maybe develops anti-GBM disease. So do you think that you also confirmed the previous studies which reported that you have the bimodal distribution, and you also have different clinical presentations where younger patients tend to have alveolar hemorrhage, and the older patients tend to have isolated glomerulonephritis. Do you think, as we don't always test for both, which I think we should, both for anti-GBM and ANCA, do you think that this may lead to some more granular phenotyping of anti-GBM disease? And do you think that double positive disease might be the reason behind that?
Thank you for the question. Well, that's actually something I found quite exciting and introduced in the discussion, that this might, you know, expose different phenotypes as seen in other diseases as well. So you have, for instance, lupus nephritis, not lupus nephritis, but lupus as a disease, as it is. You see a peak, high peak in young female, and then a gradual increase for older men, and it has been kind of, I'm not sure it's been shown, but it's actually been proposed that it could be epigenetic, differences in methylation process that kind of turns on and shuts down the genes that it's translated. And that actually changes over time, which is why when you are older, you're more prone to have some of these autoimmune diseases. And you can actually find other diseases as well, probably the same with ANCA, maybe the same, but ANCA-associated. But for instance, another phenotype that changes with age is IgA vasculitis. You have a total different phenotype, and you also have it here in anti-GBM disease. So that's why I think that there might be, the pathogenesis is probably different from these two groups, and it's actually a interesting thought that there might lie, different pathologies, but maybe it's more genetic with the young people and more epigenetic with the older people, or something like that. And maybe there's also all the surroundings. You've been exposed to something which can, release the demons, so to speak. So yeah.
Thank you.
So
great.
There are a couple of questions in the chat, and I think we can start with the first one. So, in line with what we have been speaking about, congratulations for your work, from Loreto Fernandez. And then the question is, why do you think that the prevalence of this disease is growing? Maybe we are diagnosing it better?
Yeah, I do think that this is the primary cause of the increase in incidence, is that we actually just, the testing frequency, the testing incidence is, has rocketed during the last 20 years. And of course, we will find more, and we will find more of those in the older groups, because there are more to find. So if you test in a group where the original incidence is high, you will find more, of course. So, but also I do think that there is an increase due to the growing percentage of because of the shift in demography, actually. Yeah.
Then a very good point as well from Abdelhamid Hamdi Ramadan. So he is asking about the value of repeating anti-GBM serology with and without plasma exchange, and if there are limits for titers to do or not to do plasma exchange.
All right, so this is actually maybe a more panel discussion, rather than actually the epidemiologic discussion. But I guess we have recommendations on that, and normally we tend to plasma exchange to people until they are under the upper level of the normal range, and if they stay and in at least for a certain time, and then maybe go on to MMF for a while until they become normal in their titer. I don't know what the other people in the panel what your kind of suggestions are.
I guess we all want to see either a negative anti-GBM titers or within a non-toxic level, which might be, twice of the upper normal range. I think that's the ultimate goal. And that's what, probably the good IDES studies or study number 2 will show us, hopefully, that achieving anti-GBM negativity is the most critical and important thing. And as soon as possible, I think.
Just watch.
Can I have a very technical and maybe naive question? And I think that in most labs, the anti-GBM titers are measured with an ELISA technique. Was it the same used in all studied centers? Do you know anything of it? And is there a lot of variation on different ELISA testing?
There has, so there were different, so some of the kits used were different from different centers. So we actually we used a positive test, which is either a positive test or a test that has a higher a level of anti-GBM that is higher than the upper level. So that was just how we coded it. So that is probably also why we saw a much higher incidence of the positive anti-GBM tests than what we saw of actually ICD-10 confirmed diagnosis. Because it might be that you will have patients that have if the upper limit is 10, that they have a slightly elevated anti-GBM of 12, and then they will actually confirm as a positive in the study. And that could be many reasons for that. Yeah.
So in line with that, I would just briefly ask you, I mean, I've seen the figure on advanced disease, and that was defined as hospital stay over 10 days. But in my experience, you don't get any patient out of hospital before day 14. So I was really struck by the numbers. So are the Danish people so well treated, or are you doing something special in your plasma exchange procedure to get the patients out earlier?
No, I don't think so. It might be. It's actually a good question. And for some reasons, I guess for one of the sub-studies, subpopulations, you also saw that there was a mismatch between ICU stay and length of in-hospital stay. But what sometimes happens is that the first part of the stay is at one place, and the second part of the stay is in another place. So that might translate into what we see here. Perfect. So you have an initial stay at a high a center somewhere, and then if you have a reconvalescence period, you have it maybe in another place. That might explain that.
So Lauren first.
Yeah, just to follow on from that, and just another question. So just in the paper, there was a number of people who were in ICU who didn't have plasma exchange, and I just wondered whether or not you did any sub-analysis on those that had plasma exchange and those that didn't. I know that the data before 2004 is difficult to capture, but I just wondered if it made any difference to the outcomes. And just as a separate thing, a similar thing about your length of stay. I don't know what it's like in Denmark, but there are, at least in the UK, options to do plasma exchange as an outpatient in some of our stable and well patients that didn't require sort of ICU input. So that can sometimes allow people to still get out of hospital but have plasma exchange as an outpatient. I don't know if you've had any experience of that as well.
Well, the first question is that so yes, we did do sub-analysis on plasma on those patients. That was the 74 patients that actually had received plasma exchange, and we did see actually the same. There was an increase in incidence. We saw everything was actually the same. So that's also mentioned in the sub-analysis of the paper. So mortality rate and everything is actually fitted quite well with the total population. And why we didn't find that all patients received plasma exchanges, they should probably have, but as you mentioned, before 2004, we didn't have full coverage, so we didn't capture everybody receiving, and probably there might still be a problem here. The other thing is that maybe not all patients are receiving plasma exchange. If, for instance, they don't have lung bleeding and they have, they were on dialysis with 100% crescents on the biopsy, it's actually the likelihood of them, regaining their kidney function is not very high. So sometimes you can just decide that we won't, throw everything we got after these patients, but maybe save all our efforts to when they get their renal transplant. So that might also be but if you look at previous epidemiologic studies on this, they also find around 80% of the patient receive plasma exchange, and they can't really explain why the last 20 didn't. So yeah. And the second question, so in Denmark you can have plasma exchange as an outpatient as well if you are through the main part of the disease where everything, and you're stable and you still have maybe a bit of a high anti-GBM titer, you can still have and receive plasma exchange as an outpatient patient. But I think it's very rare that this happens.
So we have one more question from the chat by Raul Bosu, and he asks about the potential relationship between COVID-19 and these diseases. And if you do see an increase in incidence, especially after 50 years, so it might not be answered by this study, but maybe a future idea to look at that.
Definitely. So this study stopped in 2018. So that was actually where COVID actually started, wasn't it? But I've seen some, I guess the Hammersmith group, they did a short letter to the reviewer in Kidney International, I think it was, stating that they saw actually a quite steep increase in cases that year or those years. And and there was another short communication stating that they saw, I think it was actually for CKJ, that they saw an increase in incidence. So I mean, it's probably too early to say anything. I think we should, let some years go and then we can look at it. But I definitely will. Yeah. Just saying that it's knowledge now that everyone knows that viral infection can actually push autoimmunity, either something you have already or might have disposition for having it. So infection will kind of push that. So you will kind of it will come to light in some patients. So we'll probably see an increase. It wouldn't, surprise me.
And that's why, we need good epidemiologists like yourself or interested in the epidemiology of these diseases. So Vanja, you raised your hand as well.
Thank you. Wanted to connect with what you and Amaryllis said, and question on antibodies. This is just my observation. Watched a lecture by Professor Segelmark and saw the very impressive diagram on the rapid negativization or rapid instant decrease of anti-GBM antibodies with imlifidase compared with undulating pattern with daily or every other day plasmapheresis. So I think that's the future, keeping them below the toxicity threshold. So I wanted to ask you, when you were talking about the rise in testing, you had a steady linear sharp rise in testing, but a relatively modest increase in anti-GBM positivity in real diagnosis. So did you also look at the biopsies? I saw that around 60% of patients in your study had biopsies. Is there a trend, such trend in the number of biopsies performed? This could clarify if this is if this trend of anti-GBM testing is due to tests or really patients presenting as anti-GBM disease. So was there a trend in biopsy?
I didn't look into that actually. The problem is that the usage of biopsies in the Danish nationwide registries hasn't really, been proved yet. So we're actually ongoing with validating these this pathological registry. So I did not look into that.
That would be interesting. Thank you.
That would be interesting. Yeah, definitely.
Yeah.
So I think we have time for one final question. And I was pretty curious. You mentioned it briefly that the frequency of plasma exchange was not close to 100%. And it seems that the younger patients didn't undergo plasma exchange that frequently. Do you know why? Because especially those had lung hemorrhage.
Yes, I guess I wondered exactly that question myself. And I guess why we're seeing is, so there was a quite high percentage of patients in the early years. There was a higher percentage of younger patients in the early years, whereas in the older years, not the older years, but the later years, patients were older. So that's why you probably, because before 2004 we didn't have full coverage, as I said, and that's why you probably see a lower percentage of the younger patients not having a plasma exchange, which you would actually expect, because they are the ones with full-blown pulmonary hemorrhage. So so I guess that's why. I guess that it's actually a technical thing more than an actual thing.
Plus, you would expect that they accept higher density of immunosuppression better than the elderly in terms of, side effects and so on and so on.
But it's important for me to say that this is epidemiology based on registries that is not, they're not made for research that I use them for, but they are actually quite good we can use them, and we can extract knowledge from them. But we have to be very, curious and not curious, but we have to know that you can't use the registries for every question. You can use it for some questions, but not every question. Yeah.
Well, Karl, Emil, that was amazing. So we learned a lot in the last 45 minutes. And thank you very much for joining us and for presenting your exciting data. And with this, I can close this journal club and announce the next one. It's on the 25th of January at 5 p.m. And the title will be, it's pretty long, All-Cause and Immune Checkpoint Inhibitor-Associated Acute Kidney Injury in Immune Checkpoint Inhibitors Users, a meta-analysis of occurrence rate, risk factors, and mortality, a very important question as well. And thank you all for your attendance, and thank you, Vanja, Lauren, and Amaryllis for joining us here.